Alright guys, let's knock this out real quick. Obviously this is going to be a little bit different type of video. I'm going to just go through my notes here and talk through and we'll see how we go. I can't get my classroom again right now. Maybe I'll try a different type of video if this doesn't go well. Just let me know in the comments and in the discussion what you think about this. I'll try to make it as interesting as possible, show you some pictures and stuff, but let's knock out some respiratory system. So start off with just respiratory system anatomy. We'll start outside the body and then go to the lungs and take it each spot in between. First off, nose is pretty straightforward. Provides an airway. It filters, warms, and cleans the air. Also moistens the air. Having some water content in the air makes the lungs work a whole lot better. You'll see in just a second. You don't want dry air because that makes your lungs not work very well. It also houses the olfactory receptors, which we talked about a bunch when we did the cranial nerves. Cranial nerve 1, the olfactory nerve, is where you're going to be allowed to smell. One other thing we don't really think about too much is that the nerves are resonance chambers, or excuse me, the nose is a resonance chamber. The way we speak and how we talk is mostly due to our nose. If we hold our nose, we sound a lot different, and we don't have the same resonance that we would if we have that open sinuses and nasal passages that allow us to bounce sounds off and provide all kinds of different things. That's why when you have a cold or when you have a stuffy nose, you sound a whole lot different as well. The external nose is mostly hyaline cartilage. It's not quite as bendy and elastic as your ears, but it does have some elastic cartilage, but it's mostly hyaline cartilage. And you do have that small bony protrusion that is at the top of your nose that is what gets broken when someone says they break their nose. The sinuses are all around. I got a couple pictures up here. This is a picture of the sinuses. Sinuses are pretty much just open spaces in and around your nasal cavity, and it just provides a place where you can trap bacteria and viruses and fungi before it gets down into your lungs. And it also, like I said, provides for the smell and the protection of your body. But sinuses are just empty space within bones of your skull, and you have 4 different sinuses. They're named for the bones they're in. You have the frontal sinus, which is like right above your nose, kind of between your eyebrows. You have the maxillary sinuses, which are right below your eyes on the maxillary bone. You have the ethmoid sinus, which is more internal, and the sphenoid sinus, which is kind of behind your nose. We can see those on dissection when we check that out. But they warm and moisten the air, and they also produce mucus. Mucus snot, if you will, is what is going to catch those germs as they come into our body, and helps protect us from the outside world, but also allow us to get that oxygen. Next up, we go past the lungs here. So we have our lungs and our mouth. We're able to breathe through our mouth because we have this common area right here, which is the pharynx. The pharynx is the shared passageway for water when we drink, for food when we eat, but also for air when we breathe, is the pharynx. 3 main sections of the pharynx. You have the nasopharynx, the oropharynx, and the laryngopharynx. Nasopharynx will be more up here where it's just air, and it's where if you're talking while you're eating or something and you get a tickle in your nose, it's because you're getting water or food up in your nasopharynx. Then you have the oropharynx, which is right in here, and then the laryngopharynx down here behind the epiglottis. This is the epiglottis. This is what flops down to prevent food and water from going down your trachea. So we have the big muscular epiglottis here. It's not really that big, right here behind the hyoid bone. I'll show you some pictures of that in just a second. The larynx is otherwise known as your voice box. That is this right here. That's where we're going to have these 2 tiny little muscles that pull this cartilage around to change the tone and pitch of your voice as you're talking. you vibrate those little cartilaginous skins, and that's what provides your voice. That's your voice box right here. Little neat little thing I was watching about that. So as you swallow, this is your epiglottis. It's going to flap down to allow for food to go back here to the esophagus. The esophagus not really on this picture. So I found this video that's kind of neat that kind of shows you how this works. And we'll make sure the volume's not too high here.
Nerves. Swallowing consists of three phases.
So,
oral or buccal phase. This is the voluntary part of swallowing. The food is moistened with saliva and chewed. A food bolus is formed and the tongue pushes it to the back of the throat, the pharynx.
Now,
this process,
if your epiglottis doesn't flop down, then the food will just as equally go down your trachea than your esophagus, even more so because the trachea stays open. We'll talk about that in just a second. So this epiglottis is essential to flop down.
Is under neural control of several areas of cerebral cortex, including the motor cortex. Pharyngeal phase starts with the stimulation of tactile vocal folds. The larynx is pulled up.
So you have your epiglottis closes, and so food and water don't get down here, and everything goes down your esophagus. Pretty cool little
with
deal
the epiglottis flipping over, covering the entry to the trachea.
That prevents us from swallowing or from getting air, from getting water or food into our windpipe, our trachea, or our larynx. The larynx provides an open airway, also produces sounds, and you can also do a neat little trick called the Valsalva maneuver, which everybody does. You just don't know what it's called, which is where you close your epiglottis. You close your epiglottis like this, and you do it unconsciously, and you increase your pressure on your abdomen, and that is it provides kind of a strain. It's what muscle weightlifters do when they're lifting up. That's why you hold your breath when you're that's why if you want to get a hernia, you hold your breath while you're lifting weights. But it's why a lot of times when you're straining, you hold your breath because you're performing this Valsalva maneuver, and this also provides the ability to defecate for some people. Is that Valsalva maneuver, that straining to increase the pressure on your abdomen to force things out of your body. All right, that's fun talk. All right, so that was the swallowing video. I want to come back to this though. So we're down here in the larynx. If you keep on going down, you get to the trachea, which is this shared passageway right here. Trachea is your windpipe. It's going to connect the larynx to the primary bronchi. The primary bronchi is just where it splits into two down here, and it stays open all the time. It's not like the esophagus. The esophagus in that video you saw was kind of floppy. The trachea stays open to provide a space for air to go, so you never have to worry about air not being able to go down there. You get these C-shaped bands of dense regular connective tissue. Now, if you remember, dense regular connective tissue gives you a whole lot of strength in one direction. Dense regulars, like tendons. And so this is why if you get punched in the neck, these C-shaped bands can actually collapse, but then bounce back almost immediately because of this dense regular connective tissue. And it's really hard to stop somebody from breathing unless you hold down this dense regular connective tissue by choking them, because the trachea does a really good job of staying open. Next up, you have your bronchi, and I got a better picture of your bronchioles here. This is what I wanted to look at for this. So you have your trachea, then you have your bronchi, and bronchi are just things that carry air to your lungs. So you have your primary bronchus going in either direction, and then it splits into secondary bronchi, then down here to tertiary bronchi, and then at the end of your tertiary bronchi you end up at the end, which is the terminal bronchiole. Terminal bronchiole are going to be the last little areas that are going to deliver air to the alveoli. The alveoli is going to be the part of the lung that actually is transmitting oxygen to the blood. So blood vessels are going to flow by here, and you're going to get that air to that spot. Now, the reason for this shape, if you notice, the trachea is bigger than the primary bronchus, is bigger than the secondary bronchus, is bigger than the tertiary bronchus, is bigger than the terminal bronchiole, because you want to get your air going evenly throughout your lungs. And so that's that design. A lot of times, if you go into a building that has their air conditioning units exposed, you'll see this same type of design where close to the air conditioner you have a big tube, but then farther out you get smaller and smaller and smaller, and so this all the air can get to everywhere equally, and you don't end up with all of the air going to one spot on your lungs. All right. This is the picture of the epiglottis I want to show you. So there's the epiglottis. This is the larynx, and so when you swallow, the epiglottis flops down, covering that the trachea, so that you don't swallow that. If you want to feel where this is, all of this stuff is right behind your Adam's apple. There's your hyoid bone. So if you feel your hyoid bone, your Adam's apple, right behind that and below it. So it's at the top, right behind that and below it is all of this epiglottis and trachea and larynx. Okay. All right. So your lungs are going to fill up your entire thoracic cavity. Um, so the thoracic cage is your ribs, and so your lungs are going to fill up all your thoracic cavity except for what we call the mediastinum. The mediastinum is where you're going to have your esophagus, your aorta, your heart, things like that. So from your diaphragm to your throat and inside your ribs, the whole area in between is taken up by the lungs. Um, the pleural cavity is just what we call the space occupied by each lung. And what's interesting about the lungs is just like the heart, there are two blood circulations. You have a pulmonary network, which is going to be blood coming from the heart to get oxygen and then going back to the heart directly. Then you have the bronchial arteries. The bronchial arteries are going to provide the blood directly to the lung tissue. So they're getting oxygen from the bronchial arteries and they're giving oxygen away with the pulmonary network. Coverings of the lungs, you have the two layers of pleura that keep the lungs safe. You have the parietal pleura, which covers the thoracic wall, which is the inside of the ribs, and then you have the visceral pleura, which is very, very thin layer that just covers the top of the lungs. All right, so how do you breathe? I got a couple slides here about how we breathe and some complicated words. But so we're just going to real quick talk about the mechanics of breathing. First thing you need to understand is that the force of breathing doesn't come from, let me rephrase, the force of the gas movement doesn't really come from anything in your body. The force of the gas movement, the force getting air into your lungs comes from pressure, external atmospheric pressure. So the force that drives air into your lungs is not your diaphragm or anything else. It is the fact that there is pressure on Earth. If you try to breathe where there's no pressure, nothing's going to happen no matter how hard you work. That's why it's really, really hard to breathe on top of a mountain, because there's less air pressure, and so it takes a lot more work to get that air into your lungs. So pulmonary ventilation, normal pulmonary ventilation, that's this whole thing, is where you lower the pressure in your chest cavity, which causes the air pressure outside to push air into your lungs. You have your quiet inspirations, which is what you're doing normally until you stop and think about it. Now you're not doing quiet inspiration. This is where your diaphragm contracts, and that increases the thoracic volume and decreases thoracic pressure. Okay, so the diaphragm is this curved muscle down here at the bottom. When it contracts, it goes down. That makes this area larger. The area is larger, the pressure goes down, air comes in. So the pressure's less here than here, air comes in because the diaphragm goes down. It reduces the pressure, pressure goes in. And you don't think about this as quiet inspiration. Diaphragm contracts, it increases thoracic volume, decreases thoracic pressure, air goes in. The reason we call it quiet is because if you're listening to it with a stethoscope, you hear very, very little sound. That's why it's called quiet. Then you have forced inspiration. Forced inspiration is where you're trying to get in as much air as possible. Not only do you contract your diaphragm, but you're also going to use your accessory muscles of your neck and your intercostal muscles, which are the muscles in between your ribs, to make the pressure even lower. So this is where you're about to take a yell, or you're about to do something, you take a big gulp of air. That's forced inspiration. Then the opposite of that, you have quiet expiration, which is quiet expiration is how you breathe out normally, and that's completely passive. It means it doesn't require any energy. and that relies completely on the elastic recoil of the lungs and relaxation of the muscles. So it doesn't take any energy to breathe out normally. It's just your lungs kind of bounce back um, to their normal spot, and the air just gets kind of pushed out of your body. Forced expiration, on the other hand, is active. Not only do you do quiet expiration, you have this passive process, but also you're going to flex your abdominal muscles, which force the thoracic pressure to increase and pushes that air out. Think about like when you're blowing something, blowing candles out, or when you're singing very, very, very loudly, you're really pushing on those muscles. Um, the different factors for ventilation we'll talk about a little bit more for next week. With pathology is airway resistance, that's the friction encountered by the air, and then the alveolar surface tension, the ability of the alveoli to expand and then contract and go back to normal. So those are super important things that make lung good at breathing. And the last thing I'm gonna leave you with, I have this picture, but I'm gonna make it a little bit prettier, is lung volumes. So this is normal breathing where you get air in, you breathe air out, you get air in, you breathe air out, you get air in, you breathe air out. But then what happens here is you blow air, you normal breathing, quiet expiration, but then this person breathed in as much as they possibly could. They got all of their inspiratory reserves, so all of their extra air that they could fill up their lungs with, and they get to their vital capacity here, which is the most they can possibly breathe. Also, their total lung capacity. Now, the difference between vital capacity and total lung capacity, if you'll notice, is vital capacity is the air that's in your lungs, and then total lung capacity is all the air in your lungs. I'll explain the difference. Because now, this person is going to breathe out as much as they possibly can. They're going to breathe out as much as they possibly can, but they're going to hit a point where they can't get any more air out of their lungs. This is called your residual volume. The residual volume is the air that never leaves your lungs and can never come out of your lungs. And so this you want to keep air in your lungs because you don't want your lungs to collapse. It's kind of like it's a whole lot easier to blow up a balloon if it's got just a little bit of air in it than to blow up one that's completely smushed flat, because it's hard to get that air back in there. So you keep a little bit of air in your lungs at all times. That's what your vital capacity is. Total lung capacity is just all the air, including the residual volume. Then the person started breathing back to normal. So important things here. This is your tidal volume, which is your normal breathing. Inspiratory reserve, the most you can breathe in. Expiratory reserve, the most you can breathe out. And then residual volume, the volume that stays behind. Hope this wasn't too awful boring. I'm gonna try to go ahead and cut it short here, but let me know if this is something we can continue doing. I got a couple more units I need to do, or I can find other videos, or I can try to do something live in my house here, where I can get some type of whiteboard or something to write on. They said there's going to be an announcement soon about schools this week, so keep in contact with that. Like I said, if we go back to schools, we'll definitely do dissection first and foremost. And if we don't do that, go back to schools, I'm going to be thinking about an interesting way that we can do dissection, where you can get the experience as much as possible, um, with the things that we can do. All right. Miss you guys, and we will see you soon. And y'all stay safe.